Well, good morning, everybody, and thank you very much. Hidden in the alleys and doorsteps of our cities and scattered throughout the countryside is a vast network of invisible, inarticulate citizens living lives of desperation, one paycheck away from disaster. The less fortunate sit on street corners where, through bad luck, bad choices, illness, or the vagaries of the economy, find themselves homeless and hopeless. America had no definition of poverty until the 1960s, when the Social Security Administration defined it as an annual income below the cost of a USDA basic diet multiplied by 3. Several years later, it was indexed to inflation. The current poverty line is $18,310 for a family of 3 and $22,050 for a family of 4. According to the traditional measure, the poverty rate in 2008 was 13.2%, or a total of 39.8 million people, and rose to 15.1% of the population of 46.6 million people in 2010. But the poverty line is not the correct measure of economic hardship. The point at which families are able to pay their bills regularly, including additional expenses for health care and education, is on the order of $36,000 annually for a family of 3 and $45,000 for a family of 4, approximately twice the traditional poverty line. Well, what is the effect of the rising level of poverty on health? Lifestyle decisions, of course, have major health consequences. However, poverty in and of itself has a major adverse effect on health after controlling for adverse discretionary health-related behavior. Studies of cumulative survival, preventable death, and level of education demonstrate a strong association between the high mortality rate and low level of education. The sharpest declines in survival occur in highly preventable diseases and in people with less than 15 years of education. In fact, Morosky and Ross argue that educational attainment is the prime driver of the relationship between socioeconomic status and health. However, educational differences were fully explained by the strong association between education and income in a longitudinal study of the effect of education, income, and health behavior on the risk of dying. This important graph clearly shows the inverse relationship between hospital days per 1,000 population and median household income. Although hospitals catering to the carriage trade are no doubt more efficient than public institutions like the one where I work, public hospitals are not that inefficient. Poverty is associated with increased risk of death across a broad spectrum of diseases in the developed world. But there is little direct association between low income and health across countries, surprisingly enough. For example, despite a U.S. per capita GDP, which is 10-fold higher than in the Kingdom of Jordan, the life expectancy at birth is actually higher in the Kingdom of Jordan than in the United States. Well, what is the explanation of this paradox? Preston found a nonlinear relationship between life expectancy at birth and per capita national income. Life expectancy is not related to increased income above a certain threshold. However, people with incomes below the national average lose more years of life than gained by people with higher incomes. Subsequently, Rogers tested a model predicting the effect of income distribution on a sample of 50 countries and concluded that unequal distribution of income adversely affects life expectancy at birth after controlling for mean income. In other words, the greater the inequality of income distribution, the higher the mortality rate. Now, the most widely used measure of income distribution equity is the Gini coefficient, which is determined by plotting a Lorenz curve, shown here in red, comparing the cumulative proportion of the population on the x-axis with the cumulative proportion of income on the y-axis. The Gini coefficient is, in essence, the ratio of the area between the green line of perfect equality and the red Lorenz curve over the total area under the green line of equality. If, for example, the Gini coefficient is 0, that is perfect equality, 10% of the population receives 10% of the income, 20% of the population, 20% of the income, etc. If the Gini coefficient is 1, perfect equality, all the income of the population goes to only one household. The higher the Gini coefficient, the greater the inequity of income distribution. The data in this table demonstrate the rising Gini coefficient and therefore the increasing maldistribution of income in the United States since 1967, the year it was first calculated. Now, these data demonstrate a direct correlation between increasing Gini coefficient and decreasing life expectancy at birth, shown in the fourth column, when comparisons are made among countries. This difference occurs despite significant variations in per capita GDP, which you can see in the third column of this table. Another measure of income distribution is the proportion of total household income received by the least well-off of the population. An important study using 1990 data clearly demonstrated that the lower the proportion of household income received by the least well-off 50% of the population, the higher the age-adjusted mortality rate. This study is particularly important, ladies and gentlemen, since it compared age-adjusted mortality rates not among different countries, but among the different states of our union. According to Dr. Buzz Cooper, the United States is really a nation of nations with large differences in healthcare utilization and outcomes in various regions of the country. Cooper's analysis of preventable mortality surprisingly divides the United States into two sections roughly corresponding to the borders of the Civil War Confederacy. The preventable mortality in the Confederate States, he wrote, is worse than in any developed country and is caused primarily by the social and demographic characteristics of the patients and the availability of health care. Remove the states colored blue from the analysis and U.S. mortality data significantly improve. In fact, living in a socially economically depressed neighborhood has an effect on health after controlling for all other variables. Within a given income level, people residing in disadvantaged neighborhoods have a higher death rate and a higher prevalence of functional decline. Exposure to a neighborhood with a high prevalence of alcoholism, drug use, and violence compound problems of deficient public education and community infrastructure, increasing the risk of isolation, high-risk health behavior, and lack of access to health care. These factors may adversely affect health through unknown psychological mechanisms associated with low-control environments. Workers employed in low-status jobs with little control are at increased risk for depression and coronary heart disease. A poor diet may account for the higher level of obesity in poor Americans. And even worse, in 2008, the USDA reported that 14.6% of U.S. households were at risk for hunger due to inability to afford food, a condition now termed food insecurity. Outstanding individuals can overcome these difficulties, but the average person is trapped in oppressive circumstances without hope of escape. The effect of geography on access to health care is even more striking when we consider the rural poor. There are vast surgical deserts throughout rural America. Lack of access to surgical care directly correlates to the mortality rate after trauma. This map from the Schecter Center at the University of North Carolina, Chapel Hill, illustrates the relationship between the concentration of surgeons in metropolitan areas, shown in the blue circles, and the higher mortality rate after trauma, shown in the dark brown areas, indicating inadequate or absent surgical coverage. The lower the concentration of surgeons, the higher the mortality rate after injury. Disparities in healthcare based on perceived race and ethnicity are pervasive and closely linked to poverty. Life expectancy in African Americans is lower than for white Americans and the risk of death higher across a wide range of diseases. But some data indicate that race may be a marker for socioeconomic status. Unfortunately, we don't have time in this brief presentation to explore this subject fully. Let's examine the effect of poverty on trauma, a disease process of great concern to surgeons. You know, I recently approached the ICU bed of a young African-American man with a gunshot wound to the head, and I was surprised to be greeted by name by the family. I was reminded that I had cared for the young man's brother, who was also fatally shot 6 months before. I'll never forget this. The patient's mother sat silently with a blank stare, a single tear slowly dripping down her cheek. A growing proportion of urban trauma is characterized by devastating, non-survivable injury caused by penetrating trauma in young, impoverished African American and Latino patients. Multiple members of the same family are at risk, and recidivism is common in survivors. The risk factors for injury are difficult to dissect from the tangled web of race, ethnicity, and socioeconomic status. Residents of poor neighborhoods are at increased risk for exposure to both intentional and unintentional injury. African Americans have poor outcome after injury, but race, as I said, may be a surrogate for income. The escalation of firearm injury among urban youth in multiple locations around the country is particularly disturbing. In a Philadelphia survey between 1986 and 1995, there was a 110% increase in the frequency of gunshot wounds in young people under the age of 17. The situation in the Bay Area is even worse. These data, generated by Dr. Samuel Chaim Schecter and presented at the AAST in September, demonstrated a 228% increase in the incidence of gunshot wounds in children in the past decade. As you can see, most of the children were black and Hispanic. But it is striking that whatever their race, they were almost all poor. 15% of the almost 16,000 trauma visits between 1997 and 2004 at Johns Hopkins were recidivists. 21.9% had only penetrating, and 34.3% had a combination of blunt and penetrating trauma. The risk of death increased over twofold for each subsequent penetrating trauma visit. Risk factors for recidivism include alcohol and drug use, homelessness, criminal activity, mental illness, poverty, and membership in youth gangs, and many patients had multiple risk factors. There is a direct association between childhood injury and poverty. Children in vulnerable families have a 10.2% rate of injury in the first year of life. Poor housing is independently associated with childhood injury, but the most important predictor is poverty. Care of pediatric trauma victims is always emotionally challenging. Care of the abused injured child is even more so. In 2005, an estimated 1,460 children died due to child abuse or neglect. More than 75% of children who were killed were younger than age 4. Nearly 70% of the deaths were caused by one or more parents. Poverty is the best predictor of child abuse. Children of families with an annual income less than $15,000 per year were 22 times more likely to be abused or neglected than children of families with higher incomes. The effects of child abuse last a lifetime. David Shipler, during the course of research for a recent book, found that most of the impoverished women he interviewed during his research had been sexually abused as children. 24.8% of women and 7.8% of men in the United States have been raped or otherwise physically assaulted by an intimate partner. 37 to 54% of women presenting to emergency rooms reported experiencing intimate partner violence at some point in their life. Experts believe that these figures underestimate the true prevalence of the problem. It is the direct cause of 1,300 deaths every year, accounting for 40 to 50% of homicides in women. It occurs in all social groups, but its association with poverty is striking. Ladies and gentlemen, poverty in America is a complex phenomenon influenced by the structure and function of the economy, investment in social infrastructure, race, sex, individual level of education and training, emotional stability, and family and community support. Mental illness, drug and alcohol use, low levels of education, and single-parent families all increase the risk. Poverty itself adversely affects the health of those it affects. Surgical volunteer networks in the Bay Area, Orange County, and North Carolina have made an organized response to this challenge. Operation Giving Back, a program of the American College of Surgeons, which serves as a clearinghouse for volunteer efforts, domestic and international, have helped, but the overall health of our nation has not changed as a result of these ad hoc efforts. Despite the emphasis on the broken healthcare system, the health of our nation, ladies and gentlemen, is a question of political economy, not medicine. The data indicate that all measures of healthcare outcomes deteriorate as the inequity as income inequity increases. Unless this inequity is addressed through investment in education and social infrastructure, the health of our country will continue to compare unfavorably with countries in the industrialized world. Correcting this problem will require the political will to make significant investment at the local level, as well as the will of the affected communities and individuals to support education, curb drug and alcohol use, and limit interpersonal violence. Now, what does all this have to do with global health? The poor health of the 46 million Americans is a national disgrace, but the plight of the 1 billion impoverished souls in the developing world is unimaginable. Let me make just a few remarks about Africa, an area with which I am most familiar. It is the home of 1 billion people and a continent plagued by war, vicious ethnic violence, and unimaginable poverty. Political instability, corruption, and devastation of the working adult population by HIV/AIDS, tuberculosis, and malaria discourage a competitive market economy and foreign investment. Proliferation of desert regions and a rapidly growing population have resulted in mass starvation. Quite simply, arid Africa can no longer feed itself. What is to be done? Well, medicine must engage in this effort, as you are doing, both at the institutional level and at the interpersonal level. And I want to emphasize that these relationships have to be long-term. Showing up in an area for 2 weeks helps the few individuals that you interact with, but really doesn't change anything. You have to maintain a long-term relationship. But more importantly, wealthy industrialized nations must make thoughtful long-term investment in infrastructure and economic development. Clean water, an adequate food supply, and jobs are prerequisites to health. Cultural change is difficult but necessary. Education, particularly the education of women, is essential to lower the birth rate, improve the financial stability of families, and raise the standard of living. Without the abolition of female circumcision and child marriage, a significant reduction in the morbidity and mortality rate of pregnancy will be very difficult. The brain drain is another serious problem. Educated professionals gravitate towards cities, are recruited by NGOs, and at worst, leave the continent to pursue more lucrative opportunities. A functioning middle class cannot exist without a functioning economy. Surgery has a critical and cost-effective role to play in improving access to health care and reducing the burden of surgical disease. However, it must be part of an integrated program in investment and economic development funded by the wealthy industrialized nations. Failure to act will exacerbate the humanitarian crisis and awaken the sleeping panther of insurrection in Africa and beyond. Thank you very much.